can. So I'll try to give perspective on that too if I think it's appropriate. So anyways, you know, traditionally bunions have been the #1 topic. That topic's kind of ebbed the last 5 years or so. Traditionally, they would ask topics about severity of like, you know, of angular deformity, what osteotomy should you do, and that's kind of fallen out of favor. We'll talk about the important features that seem to be tested on the boards that are more testable nowadays on the OITE, because there's so much has changed with bunions. We're doing a minimally invasive and all these other things. Things on flat foot are flat foot's a nice thing for them to test, and they always have questions about diabetic stuff. So anyways, we'll go step by step. Ankle arthritis has become an increasingly commonly tested topic the last 5 years, especially complications of. So we'll talk about that too. So first with bunions, you know, for the more junior people, there are 2 factors why we develop bunions. #1 is genetic. Most, especially women that have bunions, they have a positive family history, but shoe wear is thought to play a role too. It's not just a problem with the toe. It starts as a problem with the first metatarsal. The first metatarsal actually drifts into varus, and then because of the asymmetry of muscular balance that creates at the joint, that brings the hallux into valgus. And as it happens, the muscle imbalance is such that a pronation deformity occurs with the hallux, especially with severe deformity, as you can see illustrated there. The sesamoids laterally drift too. So there can be erosion of the crista that keeps them normally in place along the planar aspect of the first metatarsal. And once that erosion happens, it's harder to get those sesamoids back corrected, and you start to get a little bit more of a degenerative bunion. These are those angles that I was referring to classically. The 2 main angles that people care about are the intermetatarsal angle, which is really a measure of how varus the first metatarsal is, and the hallux valgus angle, which is a measure of how valgus the toe is relative to the first metatarsal. There are other angles like the distal metatarsal articular angle and hallux valgus interphalangeus. I don't think they're going to test those what's normal on that directly, but they will test what to do specifically if you have abnormalities in that, with a few other features that are a little bit easier to characterize. When I look at x-rays in clinic of a bunion, this is the first thing I ask. Is the deformity congruent or incongruent? You can see in that diagram in the first picture that there's a bunion, but the deformity is congruent. And this is meaning that the joint is not subluxated or dislocated. And in the second image, you can see that the proximal phalanx has fallen off the lateral aspect of the first metatarsal head. So if the articular surface is right, it's from, can y'all see my cursor? Maybe. Does it show up or no?
Yeah.
It does not.
Small on phone screens, but I can.
You could see it or no? Anyway, you can see that the joint's dislocated, right? On that second
cursor finds him.
Oh, perfect. I'm glad somebody else joined. But if the joint's congruent, that means that it's a juvenile bunion, and you sort of approach that differently. If it's incongruent, which most adult onset bunions are, then it sort of fits into the standard treatment categories. Right. Had Ed slide. It's all about congruence. If you have a classic adult bunion and you want to correct that bunion, part of restoring that correcting that bunion is restoring a congruent joint, and you do that by associated soft tissue work. Usually that's imbrication of the medial capsule. That's traditional bunion. We're starting to see that may not always be fully necessary unless there's a severe stiff deformity. If they're flexible, it may not be needed, but traditionally you need that lateral ligament release and medial capsular imbrication. Traditionally for milder deformities, we start with the distal osteotomy. The distal osteotomies are easier to control. They heal a little bit better because they're metaphyseal, but they can't get quite as much deformity correction with them, because really what you're trying to correct with the osteotomy is the varus of the first metatarsal relative to the second metatarsal. You're trying to bring that intermetatarsal angle down. So when you do a distal osteotomy, you have less power to do that. As traditionally, as your IMA goes greater than 13 degrees, you start considering doing a proximal osteotomy or a Lapidus procedure. Both of those have a little bit more power in their correction, but they come with more soft tissue dissection, and all the other same tenets apply. You're trying to restore a congruent joint, that sort of thing. Lapidus, which is the first TMT fusion with correction of deformity at the same time, has traditionally been used if there's instability at the first TMT, which some surgeons call really a subjective physical examination finding, but others define based on gapping on the lateral X-ray. So if you look on the lateral X-ray, the joint space width of the TMT will subtly be wider on the planar aspect than the dorsal aspect. But the popularity of Lapidus is really a regional thing. On the test, they won't say, they'll give you clear instability or clear arthritis in the first TMT joint in order to drive you towards doing a Lapidus. Otherwise, they won't have you do it. Wouldn't you agree, Sean?
Yeah, I think, like you said, it's becoming more popularized with what's called the Lapiplasty, but they may have that as the only option if you have an intermetatarsal angle greater than 13 and none of the other possibilities are there.
Right. Exactly.
So, so if you've got an intermetatarsal angle greater than 13 degrees and they present you distal chevron, Aiken, modified McBride, and Lapidus with a modified McBride, it's going to be the Lapidus.
Right. I was telling them
I could see them. Yep. I could see them testing the fact that you can correct rotation through a Lapidus as well. Just like they rotation once last year, and that's obviously going to be more popular.
No, absolutely, and I think that's proving out to be a factor, the rotation of the first metatarsal.
I thought that was refuted with one of, anyways, that's another topic.
Well, I mean, again, they may not do that because if there's some argument, but it is becoming more popular, and you never know what they get through on the OITE.
Right, that's the whole thing.
Question.
I was the last few years, Sean, the questions have gotten away from what osteotomy fits what angular deformity, more towards recognizing congruence or incongruence, or recognizing associated arthritis, or recognizing what to do with associated TMT instability, because those are yes/no variables that are more straightforward to test, I think has been the thought. I don't know if it was like that last year, but.
So what was the question last year, Dave, that was on rotation?
I honestly don't remember the exact question. Does anybody else recall that? I haven't looked at last year's questions.
Was it looking at rotation of the first ray, or was it looking at the subluxation of the structures around the first metatarsal head?
It was something about, they asked about an osteotomy and then said, like, what does this not accomplish or something? It might have been like asking a chevron and then saying that it doesn't correct rotation or something like that.
Okay.
Anybody remember anything? No. Okay.
Anyways, speaking of, so congruent correction. This is an interesting one. These are Haddad slides from the Miller Review, Sean.
Yeah. Well, I looked at them. Well, I looked at them this morning. So. Yeah.
If you have a congruent joint, you have to accomplish your correction through, you don't want to try to imbricate the medial capsule with a congruent joint, because that will make a varus incongruent joint, which is painful for the patient. And there's a lot of thought that, juvenile bunions done 25 years ago with the traditional method created painful patients and dissatisfied patients for that reason. So doing a biplanar distal chevron, which essentially means doing a chevron osteotomy where you take out preferentially a more bone laterally than medially, allows you to correct your distal metatarsal articular angle some. You can also address your hallux valgus interphalangeus with an Aiken, or you can use a more proximal osteotomy like a scarf to rotate as well to increase your DMAA while maintaining your joint congruence. Right, so this is Haddad's version. He does a biplanar chevron plus an Aiken.
Yeah, it is interesting that they keep putting this on there, because it is relatively uncommon that you end up doing it.
It's funny. They want you to recognize the thing that you can mess up. That's what they test for, not the commonplace run-of-the-mill thing. It's when, if you're a general orthopedic surgeon, should you not manage this and send it to somebody who's a specialist, right? Because they're kind of prepping for, anyways. So again, arthritis. If you have arthritis in the first MTP joint, if you do a fusion, it corrects your IMA at the same time. You don't need to do a corrective procedure to correct the IMA at the same time, is the point. The big complication that we don't frequently see, but that is unfortunate, is avascular necrosis of the first metatarsal head. It's never been shown to be associated with a particular type of osteotomy or lateral release. We can also see hallux varus.
When you say that, when I was a resident, that was on the waiting. It was, you don't do a lateral release with a distal osteotomy because of osteonecrosis. Then the guy named Fred Lippert went back and looked at all of his and showed that it didn't matter. And so it's interesting that it's come full around. But you just don't want to strip the head when you're doing these procedures.
Mm-hmm. So traditionally, hallux varus was the #1 feared complication. It happened because people would take too much medial eminence. They would do an excessive lateral release, essentially pull the toe over too far. It's less common of an issue now, but still something that's an issue. If you see patients come in with it, the salvage is either a tendon transfer if it's flexible, with sort of the opposite of a bunion procedure. You can take the extensor tendon and transfer it, do a medial capsular release. Otherwise, you just do a fusion. Fusion's the predictable thing. If by the time patients come to you with hallux varus, they might have degenerative change, or they may just be over it. So if you see big toe fusion for hallux varus as an option on the test, probably the safer choice, not knowing the context of it. Okay. Any questions about bunions, guys? Clear as mud. So we'll talk about posterior tendon dysfunction. We also call this adult acquired flat foot deformity. A little bit about the tendon itself. It doesn't have great blood supply from 2 to 6 centimeters away from its insertion. So similar to the Achilles mid-substance doesn't have great blood flow. Same with this tendon. This just happens to be the area where it takes a turn within its groove behind the medial malleolus. So, and then long term, if you have a long-standing flat foot, the spring ligament, your calcaneonavicular ligament, it really serves as the sling to support the talonavicular joint, it fails and your talonavicular joint collapses. So you can have pain from either one of these sites. Most people with a flat foot, when they develop symptoms, it's in the tendon. On exam, you typically see hindfoot valgus. If it's progressive and the symptoms are severe and they're long-standing, it can be asymmetric, and you'll see that loss of arch contour and the quote unquote too many toes sign. You know, this is the too many toes sign is great for a test. Functionally in clinic, you got to try to have them point their feet straight forward to really, because it's all about how they rotate their foot, whether or not you really get a too many toes sign. So maintaining perspective on where the toes are relative to the heel is really the point. A single limb toe rise is what people should be able to do if they have a functional posterior tibialis tendon, even if it's painful. And traditionally, this is what categorizes people to an earlier stage flat foot or posterior tib dysfunction. Being able to do a single indicates that you can lock your transverse tarsal joints and push off. And as the tendon degenerates, you lose this strength as the tendon loses its excursion. And it's often the harbinger of progression from a flexible to a rigid deformity. Meaning, if you lose the ability to push off with your toes, you lose the ability to lock your transverse tarsal joints and push off. Your foot functionally stays, your hind foot functionally stays in a valgus position, where the transverse tarsal joints are unlocked. And if you're in that position chronically, you get stiff. So on X-rays, we all hear about the Meary's angle. You know, eponyms aren't the greatest thing ever. It's really the line of the mid-axis of the talus compared to the mid-axis of the first metatarsal. If there's declination of that line, it indicates that there's a relative flat-footedness. It doesn't mean for sure that it's a posterior tib dysfunction problem. You can have a flat foot for other reasons, like arthritis in your midfoot. So it can't be something that you automatically say, oh, the tendon's not working because they have a flat foot. In association on the AP X-ray, you'll see valgus alignment of the heel. And then also on the AP foot, you'll see peritalar subluxation of the navicular. You can see where that yellow arrow shows the navicular spinning off the talar head. That's just what you'll see on X-ray. It's also important to look for arthritis in the subtalar joint. You'll see it where at the bottom of the angle of Gissane, at the bottom of the posterior facet, that's where you'll see the talus impacting into the calcaneus. It tends to happen as the deformity becomes progressive. Classically, stages 1 through 3 were how flat foot, posterior tib dysfunction was typified. Difference between 2A and 2B was whether or not you could do a single limb heel rise. Excuse me, the difference between 1 and 2 was whether or not you could do a single limb heel rise, and then 2A to 2B was how much abduction of the forefoot there was. So uncoverage of the talar navicular joint. And then stage 3 is rigid. Stage 4 was added. This is kind of trying to make a complex clinical problem fit into a box that it doesn't really fit into. Really, stage 4 is valgus tilt and incongruence of the ankle joint. That can happen with or without posterior tib dysfunction for a whole host of reasons. That's a whole nother discussion. But there are patients out there that have a long-standing flat foot that becomes rigid and then fails through the ankle. Anything else to mention on the classification, Sean? Anyways, they're not really, in recent years, they haven't tested, is this stage 2A or 2B? Because really it's not clinically relevant. What matters is, can they do a single limb heel rise? Is there uncoverage of the talar head? Is there subtalar arthritis? Is there involvement of the ankle? Orthotics and braces are where we start with treatment for these. Sometimes when patients come in acutely swollen, we'll put them into a boot just to get the tendon calmed down. But for long-term treatment, it's really a medial post custom orthotic. You can get an over-the-counter orthotic that's more cost-effective, but oftentimes a custom one's needed. That helps realign the hind foot and take pressure off the tendon. You don't use UCBLs, do you, Sean?
No, what I tell them is to post the medial orthotic and then to deepen the heel cup.
Mhm.
But UCBL, it's very useful, but people don't tolerate it nowadays. I think
Right.
20 years ago they did very well with this, but nowadays they don't like it. And so what I'll do is, like I said, medial post and deepen the heel cup. And if they don't do well with that, then I'll go to
People don't tolerate AFOs very well or Arizona braces very well either.
or a Ritchie brace, that's the other option.
What did you say?
The Ritchie brace, which is like a short dynamic.
There's a lot of static on your end. I don't know if.
Like I'll use a Ritchie brace. Let me see where like keep going.
I assume you're saying you use a lace-up ankle brace like an ASO?
A Ritchie. It's a articulated AFO.
Oh, yes. Okay, an articulated AFO is better than a solid for sure. Anyways, physical therapy can be.
My audio?
Yeah, there you go. Your voice better now.
Yeah, no, it's just my microphone. I had to select it off of the laptop.
Yeah. You were saying that a hinged AFO works better than a rigid.
Yeah, and they'll like it more than in Arizona too, but
Yeah.
it probably doesn't provide as much support as either of those. But that's the next stage.
Yeah. We talk about doing a tenosynovectomy and isolated debridement of the tendon. This is really for no deformity. If somebody has posterior tib tendonitis without any plantar valgus, that's the only role for that. And that's an uncommon clinical scenario. Really, the question is, what do you do with a flexible flat foot? The standard is to cut out the degenerative disease portion of the posterior tib tendon, which is thought to be the pain generator, and then take the FDL and transfer it into the medial pole of the navicular to serve as a new tendon. When we do this, we typically do a calcaneal osteotomy to correct the hallux valgus. So we displace it medially because that improves the hallux valgus, right? So MDCO is how we abbreviate that. But really, that's all that matters, is that you're sliding the heel over. This is thought to decrease the pressure once you're functionally recovered on the transferred tendon, the FDL tendon that you transferred, to take the place of the posterior tibialis tendon. It also increases the power of your FDL transfer.
And it also moves the Achilles tendon over. So as the Achilles tendon is a deforming force for valgus, it then moves it over so it is no longer doing that.
Right. And then what the foot position more distally is sort of up for debate. A lot of people will do an opening wedge osteotomy of the calcaneus to lengthen, quote unquote, lengthen the lateral column, which reduces that talonavicular uncoverage. It creates hindfoot stiffness in the process. So it really depends on how flexible they are and how long-standing the deformity is. Some people dogmatically don't like this because they say, well, the lateral column isn't short, so why am I going to lengthen it? Other people say, if you don't improve the talonavicular uncoverage, how are you going to get them a lasting result? But the cutoff for how much uncoverage of the navicular joint has been cited anywhere to be 30, 40, 50%. If they have bad abduction deformity, doing the lateral column lengthening or an Evans osteotomy is the answer on the test. And then finally, what happens long term is that patients will develop a compensatory supination of the forefoot. So when you do the calcaneal osteotomy and do the lateral column lengthening, all of a sudden you're left with the position of the foot you see in that first picture, where there's some fixed supination. Doing a plantar flexion osteotomy of the medial cuneiform brings that medial column down. And if instead they have instability through the talonavicular joint, excuse me, not the tailnavicular joint, through the TMT joint or the navicular cuneiform joint, you can do a fusion of that joint to bring it down into plantar flexion, but it's often more difficult to bring them into plantar flexion unless you use a wedge as pictured here. This is a metal wedge. They're not going to ask you whether or not to use metal or allograft or something like that, but just know that that plantar flex in the medial column is what you're looking for in your answer choice if there's residual forefoot supination. And then finally, if they're rigid, a triple or a double arthrodesis is the answer. But you can correct deformity and take their rigid hindfoot and change the position to a different position of rigid hindfoot, right? There's sort of a transition in between these two where you might consider doing an isolated subtalar fusion, but that's not, I don't think that's testable, right, Sean?
Yeah, I don't think so.
Yeah. So what they'll give you on the test is somebody who's had long-standing deformity, they have obvious arthritis, and a flat foot, and the answer is probably a triple instead of a double for the test. A double being the same thing without the calcaneal cuboid fusion. And then, you know, stage 4 is where you have deltoid incompetence. Often in these circumstances, you have associated hindfoot arthritis if it is a true flat foot and not just an ankle problem. Your options, if it's flexible, is to do a deltoid ligament reconstruction, which doesn't have consistently literature proven results. Steve Haddad's the guy who popularized this, and these are his slides, so keep that in mind. Valgus, like in that second image, doing an ankle fusion, which is really going to be a TTC fusion because they all have degeneration of the subtalar joint. That's your treatment option. And then in all of these cases, no matter the stage of the flat foot, you have to test for tightness of the gastrocnemius and Achilles. The silver skull test is so testable. They love testing it. So you assess dorsiflexion of the ankle with the knee flexed, and then again with the knee extended. And it's critical to do this as pictured in this image with the forefoot held in supination. What that does is that draws the heel under the ankle joint. It locks the transverse tarsal joints, whether they can do that functionally or not, and it allows you to really see if they have a contracture. Most patients with severe flat foot will have an Achilles contracture, meaning on their silver skull test, there's not much difference between knee flexed and knee extended. Some people with earlier stage disease will have just a gastrocnemius contracture, so doing a recession is something that's helpful. So anyways, if they'll tell you that there was no change in range of motion on the exam, and then you'll say, oh, I need to add an Achilles lengthening. But this is something every flat foot patient you see in clinic, you should test their gastrocnemius complex for tightness. Does that make sense to everybody why I'll just explain this for the juniors. So your gastrocnemius starts on the femur. So if you straighten the knee, that tensions the gastrocnemius muscle. But if you flex the knee, only the soleus is tensioned. So that's why there's the difference in the examination, because those two things come together to give you the Achilles. If it's not tight with the knee flex, but it is tight with the knee extended, it's an isolated gastrocnemius problem. Okay. Achilles ruptures. Yeah, some of the information on here is going to not fully be accurate. Would you agree with that, looking at these slides, Sean?
You know, it's a changing data point right now as far as this goes, and I think that they're probably going to push for a little more of non-operative treatment, you know, of Achilles tendon ruptures.
Yeah, it'll be really interesting to see. It all depends on who's writing them. Yeah, I don't know about the misdiagnosed thing. I mean, not 25%. I think that figure is lower than it used to be, just as far as demographics go. But typically, these are guys in their 30s who play basketball or soccer they do something ballistic where they need to push off, and the rupture occurs during an eccentric contraction. I don't know if y'all have seen the video of Kevin Durant's Achilles rupture, but his was during an eccentric contraction, meaning that he was firing his calf muscle while the ankle was dorsiflexing and the muscle tendon unit was lengthening. That's classically when it happens. Sort of during your muscles working to decelerate, right? And the tendons being pulled in both directions. People who have had steroid injections in the Achilles or on anabolic steroids or have taken fluoroquinolones recently are at increased risk. What they look like on exam, a prone exam shows it to you just with natural resting muscle tension. You'll see that the near foot is the one that has the rupture because it does not have that plantar flexion tension. Usually the rupture occurs a few centimeters proximal to the insertion, and you can feel the defect on exam. There's this named test called the Thompson test, where you lay them supine and you just squeeze their calf. Excuse me, you lay them prone and you squeeze their calf, and on the uninjured side, the foot will plantar flex, and on the injured side, it won't. So you'll be able to feel that defect and you'll be able to squeeze the calf. If their history matches this and you can feel a defect and the Thompson test indicates a lack of Achilles tendon continuity, you do not need an MRI. Functional bracing has gained a lot of traction recently, especially after one study showed that plantar flexion strength was equivalent compared to operative treatment. And that study was what, 7 or 8 years ago now? They showed an increased risk of re-rupture compared to operative treatment, but also showed fewer complications. That was compared to classic open Achilles reconstruction. Well, percutaneous Achilles reconstruction has gained favor lately. And really what it is soft tissue mindful Achilles reconstruction. Doing the reconstruction with a 2 to 3 centimeter long incision, aided by either a commercially branded jig through Arthrex or not. If you can get the Achilles reduced, that's sort of the goal of the surgery is to reduce the tear. So that's brought the wound complication rates down. But still, there's level 1 evidence that suggests that there's no difference in re-rupture rates with a functional rehab protocol. But there's other level 1 evidence that plantar flexion strength is actually better with doing a reconstruction. So there's new literature coming out on both sides of it. I think if somebody's in their 30s and is active, the answer is going to be fix it. I think if it's somebody who's older and not active, the answer is going to be functional rehab. It's really a shared decision-making discussion. I don't think they're going to say 30-year-old active, oh, the decision's non-op. Wouldn't you think don't you think that's fair, Sean?
It's controversial right now. If you go into Canada or Europe, they're going to go non-op all the way. Sports guys are going more non-op than operative. And then when you look at this, from my standpoint, and again, this is not OITE, if they've been not immobilized for more than 2 days, then I'm going to push for operation. Because if they're not treated immediately to get those tendon ends together and keep them together, and they're walking around on a ruptured Achilles for more than a couple of days, then I don't think that non-op is going to be the best option. But again, that's outside of this test.
Right.
And I don't think that they're going to push this very much because it's too controversial right now as far as operative versus non-operative. What they might ask you is non-operative in a cast versus functional rehab.
Yeah, and functional rehab is the answer. Just so you'll know, functional rehab is with a specific brace that has heel lifts in it, and it encourages early weight bearing and range of and plantar flexion only position, essentially, so that the tendon ends can heal together. You have to start it within 2 days. In the trials looking at it, that's how rapidly they started it. So if somebody shows up to you 10 days after injury, it's not really an option as much to do true functional rehab as intended. Using the percutaneous systems, there's an increased risk of sural nerve injury. That's been tested, but there's a lower risk of wound complications compared to traditional open. That's a study out of this institution. And then there have been questions before on reconstructions long-term for chronic ruptures. If it's a short span defect, you can do a VY advancement of the gastroaxillary complex. And if it's a longer segment, you can do an FHL transfer. Anyways.
Or a turn down plasti is another one.
Mm-hmm.
You go up higher and take a centimeter wide strip of gastroc from the muscle itself and turn it down into the defect.
I know it's been described. I don't know if it's been tested before, but it's an option. So the true incidence of re-rupture following non-operative is probably about 10%, not 40, but 2 to 3% re-rupture is the quoted incidence with operative, and most of the operative ones that re-rupture are probably somewhat patient compliance issues. Again, wound healing is the issue. Smoking increases that risk. Okay. Our favorite, diabetes. This is tested multiple times each year. So this is important to know. Patients with diabetes, even well controlled, if they've had it for a long time, they get neuropathy. Neuropathy is the underlying problem, the number one underlying problem. And then the number two underlying problem is that poor blood sugar control leads to poor white blood cell dysfunction. And then finally, we lose our autonomic control of blood flow. So anyways, it's sort of a multifactorial issue. On the test, neuropathy is diagnosed with a 5.07 Siemens-Weinstein monofilament. It's also called a 10-gram monofilament. You'll see the neuropathy in a stock and glove distribution. Motor involvement is much more likely to be present on an EMG than seen functionally, but it affects the perineal nerve first. And this follows everything else, every other trend in orthopedics, where the perineal with neuropathy, whether it's Charcot-Marie tooth disease or peripheral neuropathy from diabetes or from alcohol or whatever it is, it's always the perineal nerve and the ulnar nerve that are affected first. They have motor end plates that are furthest away from the spinal cord. It's just a general trend, perineal and ulnar nerve. What you'll see with people with longstanding diabetes first is clawing of the pelvis, because those intrinsic muscles are affected first, and the muscular imbalance that creates leads to the clawing. Long term, with end-stage neuropathy, you'll get anterior tibialis, tendon, and perineal weakness. Patients will also have dry, scaly skin. That's what serves as a portal for infection. Keeping patients with diabetes, it's really critical to keep their skin moist, tended to, dry, clean. Unfortunately, a lot of people with poorly controlled diabetes don't take good care of themselves, so they end up with problems.
One last thing, Sam, on that 507, It's been asked before, what does that provide you? And it tells you if they've lost protective sensation.
Yeah,
that's why you use it.
Fantastic point. Yeah. So it's not, do you have peripheral neuropathy? It's, do you have clinically significant peripheral neuropathy that puts you at risk? Peripheral neurovascular disease is a common comorbidity. This is why we check pulses on all these people. If they don't have palpable pulses, we'll look on a Doppler and see if they have a triphasic waveform. We all know ABIs. What complicates things is if there's calcification of the vessels, which there commonly is in these patients, it'll give you a falsely normal ABI. Anyways, toe pressures, which I think have been shown to be the most sensitive test for ability to heal after a surgery in a diabetic. And what matters is the 40 millimeters of mercury oxygen tension in the toe. So Right. Yeah, there you go. The transcutaneous oxygen pressure predictive of healing if greater than 40 millimeters of mercury. That has been tested. We talked about the immune system impairment. White cells, their chemotaxis is altered, and in the environment of hyperglycemia, it's also a poor cytotoxic environment. So in addition to an A1C less than 7, what we care about is total protein and albumin levels. Affecting these total protein and albumin levels to reduce the risk for our patients has not been something that's been shown to be effective. So if they give you a low albumin, the answer isn't, oh, they need to have a higher albumin before surgery. There's no evidence to support that. These are simply markers of poor metabolic function. Forefoot ulcers are the most common. Ulcers are sort of categorized in their grade by how much wear of the skin there is. If there's no break in the skin, it's just a little redness. It's grade 0. Oh, sorry, that's the next slide. Sorry. Anyways, the goal for management of the ulcers is to maintain a clean environment. Total contact casting is the standard of care. If they have an Achilles contracture, doing an Achilles lengthening has been shown in a randomized controlled trial, in addition to total contact casting, to improve patient outcomes over total contact casting alone. So that may be asked. So yeah, specifically for a forefoot ulcer.
So something that they might ask, if you over lengthen the Achilles, what happens? And they develop calcaneus because then they no longer have any plantar flexion and they get an ulcer on the calcaneus.
Yeah. So when he says they develop calcaneus, that means a calcaneal gait pattern. They bear weight on their heel. So that leads to that ulcer. So ulcer stages, not necessarily important for you to know the grades by number, but knowing whether or not they're exposed tendons or exposed bone. That's what matters. If there's exposed bone, 70% of the time there is osteomyelitis. Functionally, we treat it as if there is osteomyelitis, and that changes care. Also, you need to look for ischemia with gangrene, right? That's a really bad sign if somebody just shows up with frank gangrene or ischemia of their toe.
The other thing is a painful ulcer. You need to think about vascular underlying issue.
What we see is a probe to bone test. Yeah, this is that 70% foot ulcerations probe to bone have contiguous osteomyelitis. So that's why we use that. MRIs have a high false positive rate for osteo because of coincidence with Charcot. So technically a tagged white cell scan is more sensitive and specific for osteo. Really, it's a clinically determined thing. If they probe the bone and have edema on the bone in the MRI, it's probably osteo. Adding
How
contrast.
Question. How often do you guys actually get a tagged white blood cell scan?
I don't do it anymore just because it's so hard to get, and there's variability between institutions as far as sensitivity and specificity. When I was at Walter Reed, it was at best 50% sensitive, so I just stopped. I don't think that I've gotten one since I've been here. The other part on MRI, while you may have florid edema seen on your T2 or similar sequences, a T1 with dark dropout spots is fairly consistent with osteo. I think that the specificity is higher with that.
Yeah, the edema on the T2 is not specific, but the loss of mineralization, which shows up on the T1 as washout darkness where there should be white, that's the finding you're looking for. So, and I think, be careful ordering an MRI with contrast, because with contrast can hurt somebody that has diabetes, kidneys, and they're already at risk. it doesn't really show you much else. Getting the contrast doesn't. It'll show you if there's an abscess with a little bit more sensitivity, but the MRIs nowadays are the 3T MRIs are so good. It's not something functionally that people really use. Anyways, the wound infections that happen are polymicrobial. Getting a wound culture is not the answer. Getting a deep bone culture or a bone biopsy at the time of debridement, if you get to that point, is. And then we typically start broad spectrum antibiotics after cultures and then narrow them with the help of infectious disease. More extensive bone debridement is sort of the go-to because patients don't heal well. They have the poor microvascular flow and the poor immune response, like we discussed earlier. So, the ulcer pictured here might do well with the debridement and bone resection, but it's better to be aggressive with the initial debridement. Anything else on diabetic?
No, we're good.
Yeah. For some reason on the test, the question is always obvious. They have osteo, what's the next step? And then you kind of fall back on your call instinct, which is be aggressive with any infection. Okay, Lisfranc injuries. So this is a spectrum of injury pattern centered over the Lisfranc ligament, quote unquote, which is really the ligaments that connect the medial base of the second metatarsal to the distal lateral portion of the medial cuneiform. And the most stout portion of this is on the plantar aspect of the joint. The ligaments connect the third, fourth, and fifth metatarsals to their adjacent cuneiform and cuboid are not strong. So what happens with the Lisfranc injury oftentimes is that once the Lisfranc ligament is torn, the remaining lesser metatarsals go with the second. So the second falls laterally, and they all fall together. There's also a question of whether or not there's involvement of the medial column or cuneiforms, and that's something that we can talk about in subsequent slides. But the key is that ligament portion there. You can see on the coronal image, these metatarsals serve as sort of a Roman arch, if you will, and the second metatarsal base is really the keystone to it. So typically, these are plantar flex foot axial load injuries. Whether there's a driving force on the heel or it's simply an axial load because you fell from a height or you were in a car accident, whatever the mechanism may be, that's sort of the combination that's typical. The standard is to get weight-bearing x-rays to diagnose these. Oftentimes, if there's a complete midfoot dislocation, as you see in this larger x-ray, it's obvious you don't need to get weight-bearing x-rays. But if it's more of a sports type injury, weight-bearing x-rays are the place to start. You may see a bony avulsion of the Lisfranc. That's a quote-unquote flex sign, if you will. You can also do an abduction stress x-ray if you want to, which will show you dynamic abduction through the whole TMT complex. Even if on the weight-bearing x-rays there's no displacement, you can get an MRI to look for swelling, edema within the bone and or ligament. It's only non-op when there's not displacement, period. If there is no displacement, if there's minimal displacement, yet there's a flexine fracture, you may be able to manage it non-operatively, but that's pushing it. Standard is to fix these. And if you do manage them non-operatively, you got to follow them with weight-bearing and take repeat weight-bearing x-rays to make sure you're not missing something. Operative treatment is defined by anatomic reduction. These are had slides. There's been a big shift in our world towards fusion of these injuries. Not necessarily for isolated ligamentous Lisfranc injuries, but the more displacement of the dislocation there is, the more we're pushed in that direction. The reason is that in 2006, a randomized trial came out for low energy sports type Lisfranc injuries, comparing ORIF with screws, mind you, not bridge plates, but screws across the joints to primary fusion. And they found that primary fusion patients did better, had less reoperations, better functional outcome scores. And even the primary author of that paper has not started fusing everybody, but it's sort of given us some perspective that in the right patient, doing a fusion from the beginning is probably the right thing to do. More and more as a field, we've moved towards bridge plating, trying to spare injury to the cartilage surfaces. Do you have any comments on that, Sean?
No, I definitely do more bridge plating now than I did a while back, but at the same time, I'm doing more fusing now than before at the same time. So young kid, not destroyed, Lisfranc complex, I'll probably bridge plate and put screws in. Older individual like Randy McKnight, then I'd definitely fuse him.
Yeah, for sure. And anything high energy that there's good bone stock and there aren't comminuted metatarsal base fractures, we're fusing too.
Yeah.
Anyways, sometimes you see lateral column instability at the 4th and 5th TMTs, despite appropriate anatomic reduction of the 1st through 3rd. And that can require open reduction with percutaneous pinning with K-wires. We do not have literature to guide us on that. I don't think you'll be tested on it. Right. Primary fusion, as you can see here, confirmed through randomized prospective trials. The crux of that. Make sure to get weight-bearing X-rays, get a weight-bearing CT sometimes if you're concerned, because you can get that functionally in the office, and then consider an MRI if it's still something that's inconclusive. Bridge plating for young patients, fusion for old, or not really old, just I would say, middle-aged to old, or for bad injuries.
Do you want me to take over, Sam?
Sure.
All right. I mean, we can split it up. It's up to you. You like to talk, so I don't care. I've
been in clinic all day. I'm sick of talking.
So have I. Would you want me to share, or you just want to keep the slides on your screen?
I'll just keep them on mine, and I can. Right. You can
go to the next one. So MTP joint. So hallux rigidus. What is it? It's really arthritis of that joint. So why do we call it hallux rigidus? It's because it's stiff. There's a lot of other names: hallux primus elevatus, dorsal bunion, hallux limitus. Those all mean the same thing. So as they get grade 1, you don't have any joint space collapse. You may see a couple of bone spurs. Go ahead, next one. So grade 2, you're starting to see some joint collapse, but the joint is still there. And then you start seeing the bone spurs on top. What you want to do when you evaluate these ones is not only dorsiflex the toe, but do a mid-axial grind just to see if they have any pain in that joint that's not related to the bone spurs. You can go to the next one. Grade 3, severe osteophytes, your joint space is essentially completely collapsed. Go on to the next one. And then grade 4, they didn't show it here, but there is a grade 4, which is essentially no joint whatsoever, just completely obliterated. Not a lot of difference between 3 and 4.
So a couple things. The distinction between grade 3 and 4 is based on that mid-axial grind test. It's popularized by Mike Carol Jones' fellowship director. And it's a positive mid-axial grind test is predictive of failure of anything but fusion.
Yeah.
And then also in early grade disease, so the arthritis in hallux rigidus starts in the dorsal joint. And it happens that way because cartilage is not good at resisting shear stress. It's good at resisting axial load, right? So our big toe joints, they see shear though. So people that do lunges, burpees, yoga, that type of thing, and they put their their big toe into a loaded position of dorsiflexion, it shears the cartilage on the first metatarsal head, preferentially in the dorsal joint. But on the AP foot x-ray, you won't see joint space narrowing because the center of the joint hasn't narrowed yet. So in early stage disease, it's all dorsal, and then it progresses plantar.
So your, conservative treatment, that's your first line. Extra depth is just because of the dorsal bunion. So when we say dorsal bunion, that's talking about the osteophytes that you have a lot of times. You can have an elevated first ray in other instances. Fiber foot plate, that's just decreasing the stress across the joint. And so that's a Morton's extension when it's just the single area that's under the big toe.
You can tell this is an old guy's slides because that was the only shoe option back in the day.
Yeah.
Anyways, yeah.
And so grades 1 and 2, dorsal kyleectomy, what you're doing is shaving off that dorsal part of the bone. Some people say 30% of the metatarsal head. You do want to make it as a good transition in that area. And then I do add a Moberg osteotomy. What that does is it just takes some of the stress off of the joint. So if you think about it, when that toe has to dorsiflex, if you've taken a wedge of bone out, it doesn't translate that dorsiflexion to the joint to the same extent. And that's the way I think about it. I don't know if they'll ask that on a test or not, but. So grade 3, I do a lot of fusions. So, they may ask you the position, neutral rotation. So if somebody has a huge hallux valgus, so their toe is going to be pronated, so you need to reduce it as far as rotation. And then 10 to 15 degrees of dorsiflexion and 5 degrees of valgus. I use a flat plate and then have about a 1/4 inch between the flat plate and the IP joint when you look at them on the lateral to get my dorsiflexion. I've redone multiple hallux MP fusions, fortunately not my own, out there that have been placed into too much plantar flexion. They then have to vault over that IP joint, and it's very uncomfortable. Keller arthroplasty, I haven't done one in 16, 17 years. I think it's mostly a thing of the past. But if you have somebody that comes in with a really bad joint and they don't want to do a fusion, and maybe they're too old to be able to tolerate non-weight bearing or minimal weight bearing, then you can do a Keller where essentially you resect the base of the phalanx. It also works for hallux valgus. But
I said you should do a Cartiva.
Yeah.
I'm joking.
I'm not a big Cartiva fan.
Yeah, me neither. Big toe fusions are the best tolerated fusion that we have, period.
It's my, if I were to pick what is my most successful surgery, patients are the happiest, it's a big toe fusion.
Right. And it's functional too. I tell patients that Leighton Hewitt, the Australian tennis, played Manchester Championship tennis with a big toe fusion.
Yep.
So,
I used that line today in clinic.
I don't know who I picked it up from, but
I think it's Bob.
Yeah, probably.
So we'll go on to the next slide here. It looks like a busy slide.
Yeah.
So, what you're looking at is if you have a deformity, what's causing those deformities? So what muscles? So this is all anatomy. And then what is going to be the opposing force? Okay. So with equinus, straight equinus, you're going to have your dorsiflexors versus your plantar flexors or your gastroc cavus. Again, plantar fascia and intrinsics to an extent, and dorsiflexors. I don't think I've seen that one just by itself. Varus, you're going to have tibialis posterior and anterior because they both attach on the medial foot. And then your peroneus brevis is going to be your opposing force to that. So you will see this if somebody has a peroneal tendon rupture, or I've seen gunshot wounds to the lateral foot where the peroneus brevis is taken out, and they'll come in 3 weeks later with a varus foot because of there's no opposing force to that. Supination, again, that's your tibialis anterior. It comes down, wraps around your cuneiform, and when it activates, it supinates the foot. And again, your peroneus longus, where that attaches, is the base of the first metatarsal. So it's really in the same general position or place where the tibialis anterior attaches, but it pulls in the opposite direction. Flat foot, peroneus brevis versus your posterior tibial tendon. I'll many times take a peroneus brevis and transfer it to the peroneus longus in a flat foot reconstruction. Equinovarus, so you have your gastrosoleus complex, posterior tib, and anterior tib. Those are opposed by your peroneus brevis and longus. Equinovalgus is going to be your gastroc and perineals versus your posterior tib and your anterior tib. I'll sometimes see something along this, equinovalgus, in somebody with a tarsal coalition, and it's almost like they have perineal spastic flat foot. Calcaneovalgus, so your first foot dorsiflexors and everters, and this is what we had talked about. So if you over lengthen your tibial or your Achilles and your dorsiflexors are intact, when they walk, they'll put their weight on the heel, and they'll get an ulcer on the heel. And once they have an ulcer on the heel, it's below-knee amputation is in their future. So go to the next one. So equinovarus, most common following stroke. Again, you want to wait for at least 6 months, and what you're waiting for is essentially what is going to be the long-term outcome. I'll many times wait a year for this type of thing.
Yeah, I think a year, at least 9 or 10 months.
Say again?
At least 9 or 10 months. Yeah. Wait.
So overactivity of the tibialis anterior with contributions from the FHL, FDL, and then the tibialis posterior. And essentially they're pulling that foot into equinus as well as varus. And so it's almost like development of a club foot, after a stroke. So again, non-operative, AFO fitting, physical therapy. I have used Botox. I have not used phenol into the muscle groups. And essentially what you're trying to do with either of those is make them so that they can fit into an AFO. Almost anything that you're doing with this patient population is just trying to make them braceable. It's not to make them as functional as they could be. It's so that they can be in an AFO. So surgically, a splat, you're going to take a split of the tibialis anterior, take it that split laterally. I have never done a flexor hallucis longus tendon transfer to the dorsum of the foot. I don't know if you've seen that done, Sam, or heard that. I many times will release the flexors to the toes, especially if they've got essentially a flexible claw toe or something along those lines. And then again, usually with these, you're going to have to be doing an Achilles tendon lengthening because both the gastroc and the soleus are involved.
I find it fascinating that post-tib transfer isn't listed. If they've got post-tib strength,
well, yeah, I think that they still have some function of the perineals. And so I don't know
depends
why.
on the patient.
Yeah, you have to examine, but I think what they're trying to get at here is that when you've got a stroke patient, you really need to think about that tibialis anterior and do something with that.
Yeah, you really need to get a legitimate strength evaluation on every tendon to see what you're lacking, see what you need, and make a plan.
And part of it is where are they spasming? For this, it's going to be, what tendons. So when you feel them on their foot and ankle, you'll feel which tendons are tight, and you're trying to determine what is spasming causing the deformity. We don't have where Sam came back from in Dallas, they had a gait lab where they could do EMGs at the same time, and they could look at this kind of stuff and tell you which muscles you needed to transfer.
It lost funding in 2018, unfortunately.
Oh, really?
Yeah.
So you didn't do that. So let's go to the next
No.
slide.
But this is not in the setting of a foot drop. This is, anyways. Here we go. Foot drop.
So foot drop, again, usually a peroneal nerve palsy, and that's why I brought up the involvement of the peroneals. You can have a foot drop in the setting of a anterior only compartment syndrome, and that you'd have to look at carefully when you take the posterior tibial tendon. Again, a bunch of different etiologies. The most common that you guys are going to see is going to be traumatic, but you can have a lot of different things that can cause it. So you've got loss of the ankle and toe dorsiflexion, and then again, if it's a common peroneal nerve injury, you also lose the ankle eversion. So DPN, just when you think about it sensation-wise, that's the first toe web space. And then over the dorsal and lateral, well, it's really dorsum of the foot is going to be your SPN. A lot of times your lateral foot is covered by the sural. And then, so treatment, observation, AFO, they need to stretch like fairly extensively in order to maintain the Achilles. They're going to fit into an AFO. If they've got an acute injury, then you can do an acute repair. Nerve transfers or something that's up and coming, as far as is essentially even transferring a muscle tendon unit into this area, but I don't think that they would ask this. The most common is going to be your tendon transfers, and the eponym for this is a bridle. And usually that's what you're doing is taking the posterior tibial tendon, and for a bridle, you bring over the peroneus longus in addition after it's been tenodized to the brevis on the side of the foot. And essentially that provides you, a grade 3 strength as far as dorsiflexion, possibly grade 4. They do stretch out over time. Can you go to the next slide?
Yeah.
All right, so peroneal tendon subluxation dislocation. Go to the next one. So, the main thing is that you may see an MRI, and they may ask which one is the peroneus brevis versus the peroneus longus tendon. The peroneus brevis is the kidney bean shaped one that's next to the fibula, and the longus is behind it. Usually it's on an axial MRI. If it is a lateral or a sagittal MRI, then it's a little bit harder to determine which tendon it is without being able to scroll through the MRI. So the tendons are held behind the fibula by two different things. One is a retrofibular groove, and then the other is the superior peroneal retinaculum. There is a cartilaginous onlaga that is at that ridge. And if somebody dislocates the peroneals, it doesn't rip the superior peroneal retinaculum in half. What it does is elevate it off of the bone and allows the peroneal tendons to come onto the side of the bone. So degenerative tears, more common with people with cavovarus. And if you think of the foot as like a three-legged milking stool, and that one leg is off to the inside, and the one that towards the front is short, you're always going to fall to the outside. So these people are constantly overworking their peroneals, just like somebody with a flat foot is constantly overworking their posterior tibial tendon. Acute ruptures are uncommon. I've seen several peroneus brevis tendon ruptures, usually in cavovarus foot. You can get the peroneus longus to rupture if there's an os peroneum underneath the cuboid that can cause that. Longitudinal split tears are difficult to see on the MRI. They'll probably, I don't think I've ever seen them on the OITE saying, is this a split tear in the peroneus brevis or longus? They may say, what tendons are involved if, like in that upper right image, there's a bunch of fluid around the peroneals. they may say, you may have to say peroneal tendons. I use ultrasound in our clinic at this point, looking for subluxation or dislocation. I typically on examination can tell it fairly easily, have them plantar flex the foot and then evert and keep your fingers on the tendons, and you can feel them come and perch on the posterior fibula or even dislocate. You can go to the next slide. So again, operative, yet I try to avoid operations if at all possible on the peroneal tendons. They don't take a joke, they scar in horribly after you operate on them. But if you do have to operate, you can do longitudinal repairs of the split tears or even side-to-side tenodesis of the longus to the brevis. If greater than 50% of the tendon is involved, usually for me it's even more than that, or if they've had a peroneus brevis tendon rupture. If they've ruptured both tendons, I think that there's two options actually. One is the flexor hallucis longus tendon transfer to the base, and what you're doing is taking the tendon in the midfoot and then bringing it all the way back through to the lateral side and then taking it down to the base. If they have a cavus foot and Varus deformity, I'll many times take the posterior tibial tendon and transfer it to the peroneals because that's my major deforming force for the cavus foot. And then if they've got a hindfoot varus, you've got to do some sort of calcaneal osteotomy, whether it be a lateral translation, whether it be a Dwyer, or whether it be some sort of Z cut. And so they're just going to say calcaneal osteotomy and then, lateral translation or lateral correction.
Yeah. What do you mean by Dwyer? Can you clarify that? So
Dwyer, you're taking a wedge out. And so you're taking the cut and you're taking the laterally based wedge. A Malerba, you're taking a Z-cut osteotomy and your laterally based wedge is actually on the horizontal plane. And you can get correction through your wedge as well as you can spin the calcaneus. I've gone to more utilizing minimally invasive techniques for my lateralizing osteotomies. And the reason being is that you can do your correction through a 1 centimeter incision. And if you have to do anything to the peroneals, then you've got much less of an incisional problem. Anderson and Hammett put out a paper 2004 looking at the angiosomes, and you can have like a 2 centimeter bridge in between these incisions if you're doing a calc osteotomy and treating the peroneals as well as the ankle reconstruction, but you do have increased risk for wound healing. So since I know it, Walt Beaver actually had a cavovarus foot, and Anderson did a calc osteotomy on him and had fairly significant wound healing complications afterward. So anyway, there's your ancient trivia. So when you've got the peroneal tendons that are dislocating, in my mind, you do need to do something to the groove. I don't think you can leave that alone if the tendons have dislocated. I don't think you can repair the retinaculum well enough. I do do a vest over pants repair when I do it. So, again, this is that forced eversion. I use it in plantar flexion as far as testing it, but this is when people have the injury. They talk about creating a peroneus brevis split tear when you have subluxation of the peroneus brevis on the posterior lip of the fibula, and essentially it's running up and down and making a split tear in the brevis.
They're not going to test whether or not the groove deepen the groove.
No. Ankle arthrodesis. So use this the majority of the time in under 50. There's a bunch of different etiologies. Of course, a pylon fracture. AVN of the talus, it's a hard fusion to get, but you can make it work. And again, these are typically in patient 50 in this day and age, but they may ask you active individuals, major bone loss, those type of things. Neuropathic arthropathy, you can't put a total ankle in. And so if they have significant neuropathy, you're going to do an ankle fusion and not a total ankle. And then you can utilize it for a failed total ankle. But again, they won't ask the specifics on that. So just know your optimal position, 5 degrees, 5 degrees, 5 degrees. They talk about the posterior talar translation, and what you're trying to do is shorten the lever on the forefoot. So where your ankle rotates over, then you have less forefoot to essentially vault over and pressure in that area. Arthroscopic arthrodesis, they say that the fusion times are about 3 weeks faster. You do have to have a congruent joint in order to do this. So you can't take a lot of deformity and do an arthroscopic. I'm sure there are people that do, but they probably do. That's all they do. Our open approaches, transfibular has been present for quite a long time. We do typically anterior approaches. And then again, staged if you've got infection. You can also treat them in a frame and do what's termed a Calendrucio device, which was half pins through the calc and through the tibia that essentially then had rods that compressed across it.
You'll never see that.
No. Well, you can do it you can also do it in an Ilizarov.
Yeah.
Which you will see.
Yeah, Dave, Thursday.
Oh, you have a dislocated Charco?
Infected, dislocated ankle fracture.
Yeah. Was it mine?
No. Some guy in Gastonia.
Yeah. No, Olson.
No.
So these are some of the different ways. Of course, the left is a tibiotalo-calcaneal fusion. You can use screws. I would typically say, and this is more for your practice in the future, if you're going to do a transfibular approach, replace the fibula, just in case later on they want to get a total ankle. Let's say 15 years down the road or something like that, it makes it feasible to do a total ankle.
Yeah, y'all are all thinking that's crazy, but if they get adjacent joint arthritis and you give them a pan-talar, they will hate you forever. Yep. So a fusion takedown is a legitimately indicated procedure sometimes. So anyways, leave the fibula.
So we use quite a few IM nails, again, load sharing device. You'll see us, we'll be fairly dogmatic about which nail we use nowadays. Just because of the nitinol compression. It provides 6 millimeters of active compression. Again, contraindications are going to be active infection, vascular disease, and then severe tibial malalignment. I had one that I'd planned a nail on, but he had a plate on in Vietnam over 50 years ago that we couldn't get off, and so we had to do an Ilizarov or a circular frame. Diabetic Charcot arthropathy, you guys see that all the time when you're on our service. Essentially, this is typically in diabetics, but it doesn't have to be. When Charcot originally described this, it was in syphilitic patients because of the syphilis caused them to have lack of sensation, and so they would get essentially these dissolved joints. Again, your Eichenholz stages, it's a combination of clinical as well as radiographic evaluation. And essentially you have initial fragmentation and then gradual consolidation, and then looking at the foot as far as the resolution of swelling determines the stage. Again, commonly confused with osteomyelitis just because of the swelling in the patient population, but again, Charcot typically gets better with elevation. I would love to hear your thoughts on the Brodsky classification, if you ever used it, those type of things, Sam, since you were with him.
Yeah, so there are a couple of different classification schemes. Eichenholz is a clinical staging based on acuity, right? Are they swollen and red still, or has their swelling gone away, and have they consolidated? The Brodsky classification is my fellowship mentor. It's just really an anatomic classification. Type 1 being the most common, yet least clinically severe. Most frequently, it can be treated non-operatively. It involves the TMT and NC joints. Progressive collapse can lead to a rocker bottom foot and a midfoot ulcer. Type 2, hindfoot, often leads to instability within the peritalar joints, and that more frequently leads to an ulceration. And then involvement of the ankle, often instability as well with an ulcer. You know, a patient shows up walking on their talus or walking on their fibula. So 2 and 3 are more limb threatening, certainly. 3B is kind of a forget that.
Yeah, I don't think I've ever seen that.
No.
And just, when we look at it here, we tend to do beams and bolts for type 1. When you get into the type 2 and type 3, then we tend to do a TTC fusion.
Yeah. Charcot is an interesting process. Why it happens. Neuropathy is the underlying problem. If it's somebody who's alcoholic, or somebody who simply has idiopathic age-related neuropathy, or somebody who had chemotherapy in their 30s to treat leukemia, if they don't have neuropathy, they don't have Charcot. And what the neuropathy does is leads to almost a hyper-inflammatory derangement of the synovial lining of the joints, in which the osteoclasts are hyperactive, and the osteoblasts function is suppressed. And for whatever trigger, usually it's not traumatic, usually it's just a normal repetitive weight bearing of normal life, you get fragmentation of a bone or fragmentation through a joint, and that stirs up an inflammatory response that gets accelerated by this osteoclast osteoblast imbalance, and then you get a full-on stage 1 Charcot where they're acute, hot, red, swollen. Blood flow is good in Charcot, so that's the big thing that's different about Charcot than our classic diabetic picture. These patients typically have good blood flow and typically have good pulses. And there's something about the neuropathy that leads to autonomic dysfunction that brings in at least reasonable large vessel blood flow. That doesn't take away the microvascular disease, but that's the underlying pathology. So we kind of know why it happens. It's still not something that's super well understood. They won't test you on that. But anyways, if they have an ulcer, don't put fixation in them.
Yeah. So that's been proven out of this institution. If you've got an ulcer and you put beams and bolts in them, then it's a much higher complication rate.
Right. So
what's the next one? Are we done?
No, it's look at Haddad's plantar plating.
Yeah.
We don't do that.
Yeah, we don't tend to do that. So again, what you're trying to do is recreate the alignment of the foot and take that pressure off of the midfoot area. You have to do a tendo-Achilles lengthening. That's probably one of the mainstays of this, is getting the heel back down. And then we don't do plantar plating. We tend to do beams and bolts or frames if they have an ulcer. If they've got a stable deformity and an ulcer, you can do a exostectomy. The ulcer is typically under the cuboid area. And so you approach that laterally and then take that prominence off.
Yep.
Again, one of the mainstays is always going to be either a gastroc recession or a tendo-Achilles lengthening. All right.
That's it. Who else still paying attention? I see Olivia.
Olivia, yeah. Randy won't leave until I leave.
What questions do y'all have? Anything from last year's OITE that you're curious about? Anything that confused you? Any other topics y'all want to cover? Hey, Stu.
Yeah, we got Risa, we got Stu. Andrew, is that everyone that's left? Everyone that wants to go into foot and ankle except for Randy, right? Holy cow, do that again. Elaine. Wow.
She's sleeping.
How old is she?
She's 5 weeks.
That is awesome.
Thought I would
Oh.
share.
I'll come over to your house and I'll just sit on the couch and hold her, okay?
Yeah, sounds perfect. You're welcome anytime.
All righty. All right, well, if there any questions, feel free anytime to, just send us a line, okay?
Who's on call this weekend?
Sounds good.
Thank you.
Not me.
Anybody? Are you on call with me, Matt?
Oh.
I'm
Landon
Friday,
it.
Sunday.
Landon
No, I'm
is
Saturday.
Friday, Sunday. Switch with
All
me.
right. Well, have a good night, guys.
See y'all.
Thank you.
Thanks,
Thank
guys.
you.
Thanks.